Diana Christopher, and I am the lead dietitian on the nutrition support team at the University of Alabama Hospital, Birmingham, Alabama. Hello, my name is Diana Christopher. I'm the lead dietitian at UAB Hospital on the nutrition support team. Our team is comprised of a trauma surgeon, registered dietitian, and pharmacist for all aspects of ordering and implementing and monitoring TPN. Our purpose for our poster and for the team itself is to provide safe, up-to-date, appropriate nutrition support to individuals who are at risk of malnutrition or are already malnourished by doing so in a coordinated, multidisciplinary fashion at a large academic medical center. Our secondary aim is related to quality issues of appropriate parenteral nutrition initiation and cancellation, to also cancel bags for patients who are going home on TPN by canceling the day of if they are not going to be here to receive it that night, and then also the reduction of placement of inappropriate central lines. So a small pharmacy study was completed at the end of 2017 that showed an opportunity for improving nutrition care plans in approximately 45% of patients receiving parenteral nutrition. At that time, parenteral nutrition was ordered by residents, and then the floor pharmacist would verify each order for patients on their floors. Having a centralized nutrition support team was determined to be best practice, and therefore the nutrition support team at UAB was established per ASPEN recommendations and guidelines. In 2020, late 2020, the hospital implemented the nutrition support team, which is comprised of a trauma physician, pharmacist, and dietitian to oversee all operational aspects of our specialized nutrition pathway. As most of you are probably well aware, parenteral nutrition is the IV administration of nutrients needed to sustain life, including carbohydrates, fats, protein, water, electrolytes, vitamins, and trace elements via a central or peripheral line. And these components are individualized for patients according to their primary diagnosis, chronic diseases, fluid and electrolyte balance, acid-base status, and other specific goals of nutrition. For the poster itself, we completed a retrospective review of data we've been collecting for patients with consults we receive to accept or decline whether they are appropriate for TPN. So the results that we found since the inception of the nutrition support team, we've averaged about 40 consults per month, with 32 consults being indicated for parenteral nutrition per ASPEN guidelines. We've saved over 5 bags per month by canceling TPNs for patients who are discharging that day. We cancel the order since they won't be here to receive our TPN, which hangs at 9 o'clock at night. And then we've also saved on average about 3 central lines from being unnecessarily placed per month. So the conclusion that we came to is that the nutrition support team here at UAB can increase quality of care by optimizing patients' nutritional needs, reducing costs by preventing unnecessary or inappropriate TPN initiation and administration, reducing associated central line infections by reducing unnecessary central line placement, decreasing length of stay, and reducing transcription errors by having a team dedicated to the nutrition care pathway. The team will get a consult for TPN. We evaluate whether TPN is indicated, whether the patient has a functional gut, is there a mechanical obstruction, is there any other way that the patient can get oral or enteral nutrition, degree of malnutrition, and then if the patient is approved for TPN, at that time we would contact our central venous team that places central lines to have a central line placed. Otherwise, we might do PPN for a few days. And then we follow up with the patient every day to determine whether they need TPN still on a day-by-day, case-by-case basis. And then we wean very closely with the primary team to monitor oral and enteral intake and transition off TPN. Thank you so much for your time, and please see the following attachment.